Look at how gorgeous the last of this sunset is, but oppositely, I'm so sorry if you're on shift, we have a full moon tonight. But let me set this up and talk to you guys about invasive hemodynamics. And we measure these invasive hemodynamics using a tool called the pulmonary artery catheter. The other name we call it is the swan ganz. So this is a catheter that gets floated into the right side of the heart. So the right side is deoxygenated blood, right? And the purpose of the right side of the heart is to push blood to the pulmonary vasculature where it can pick up oxygen molecules, work its way back around to the left side of the heart where it pushes it out into systemic circulation in order to perfuse and oxygenate the rest of our body. So why do we put in this pulmonary artery catheter? Well, it's to monitor the perfusion status on our patients. And what do we call a patient who's not perfusing well? Yeah, these patients are in a shock state. So aren't there easier ways for us to determine shock state? Yeah, we could check their blood pressure and look at their shock index. Why do we have to do the pulmonary artery catheter? Well, because with our patients, we need to know exactly what kind of shock. Because think about the different types of shock that we have. We have distributive shock, obstructive shock, cardiogenic shock. Can we treat all of those shock states exactly the same? Okay, let's take a patient in cardiogenic shock. What's broken? Yeah, the pump. It's a pump problem. And so we're going to treat these patients by giving them a positive inotrope, like say milrinone or dobutamine, to help improve contractility. And every time the heart pumps, we want it to push out a little bit more blood to correct the shock state. So we'd use an inotrope. What about a patient who is in, say, hypovolemic shock because they've lost a bunch of blood? How can we treat them? Is an inotrope going to help them? Absolutely not. They need volume. They need blood products or fluids, depending on what it is that they're missing. So we can't treat those two shocks the same. What about a patient who is in distributive shock? Maybe they've got a neurogenic shock because they fell out of a tree stand and now their brain can't talk to the rest of their vasculature. Yeah, their vasculature has gone bleh, and they've lost their vascular tone. Is a positive inotrope going to help that patient? No. Is volume going to help that patient? Maybe a little bit, but what they really need is a pressor to shore up that vasculature so that we can shrink the tank to be able to perfuse the patient appropriately. So now we know why we need a pulmonary catheter. Let's talk about how to use it properly. So it floats into the right side of the heart, and it actually has two spots where it measures pressure. One of those openings that is measuring the pressure sits in the right atrium. We're going to call that our CVP, our central venous pressure, right? And that's going to indicate our preload, how much pressure of blood is coming back to the right side of the heart. Then the second pressure sensor is on the very tip of the catheter, which is going to hang out in the pulmonary artery. That's the big artery that comes out of the right ventricle and sends blood down to the pulmonary vasculature. Now, this swan ganz also has a lot of calculated pressures that it will give us. It will tell us the SVR. That's our systemic vascular resistance, right? And that's measuring how tight the vasculature is, right? Think about if you're in anaphylactic shock or septic shock or neurogenic shock, that SVR is going to be super low. You've lost your vascular tone. It's gone bleh. And also cardiac output and index. Normal cardiac output is 4 to 8 liters per minute. That's the volume of blood that's being squirted out of the left side of the heart per minute. But think about me as a 5'5", 150-pound female versus Shaquille O'Neal. He's like 7 feet tall and 350 pounds. If I put out 4 liters a minute, it works for my frame. If he puts out 4 liters a minute, it is totally not enough to keep him perfused. So somewhere along the way, someone came along and said, what if we create a formula to turn cardiac output into where we take out the variable of how big the person is? And that's called cardiac index. And normal for that is 2.5 to 4. So you have to do a little bit of memorization of the normal values. Our normal CVP is going to be about 5 to 8 millimeters of mercury. I just had a brain fart and forgot the label on that, right? So that's our CVP. Our normal pulmonary artery pressure is going to be, remember it, quarter, 25 cents, 25 over dime, 10 cents, right? So 25 over 10, quarter over dime, is our normal pulmonary artery pressure. And then our normal wedge pressure, which is also taken in the pulmonary artery, but that's when we inflate the balloon that's at the almost very edge tip of that pulmonary artery catheter. That allows us to measure the pressure that's hanging out in the pulmonary vasculature. We essentially close the door so the right ventricle can't push in blood, so we don't keep that balloon up very long at all, right? Because that means no blood is going from the right ventricle into the pulmonary. So we do that just to get a quick look at the pressure in the pulmonary vasculature, which can also be a surrogate for our left ventricular end diastolic pressure, but that's getting into a little bit of the weeds. I just want to cover the very beginnings of the basics of the pulmonary catheter. So what are we going to do with all of this information? Memorize those normal values, and then if you're sitting for a test like your CFRN or your FPC or your CCRN, they're going to give you a hemodynamic profile and ask you to determine, so differentiate what type of shock this patient has based on that hemodynamic profile. But in real life, you're going to get a patient who's giving you all of these values, and you're going to have to put that information together with their vital signs and their history and their clinical presentation to figure out what to do next to best care for this patient. So let's think about the different shock types. Let's start with an easy one like neurogenic shock. What's going to be the hallmark on the hemodynamic profile of these patients? Yeah, their SVR is going to be super low. That's the problem. That's what caused the shock state, is we lost all vascular tone. So we're going to have really low SVR. In addition, you can look at these patients' vital signs, and what's their heart rate going to be doing? Yeah, it's going to be mega slow. That's the hallmark of neurogenic shock is low blood pressure and a low heart rate. Of course, their cardiac output is going to be crap because they're bradycardic, right? So the cardiac output is their stroke volume, so how much blood the left ventricle is squirting out, times the number of times per minute that it's squirting blood out, so your heart rate. So if that's low, of course our cardiac output is going to be inadequate. So that's easy peasy to see that neurogenic shock. What about a patient who is in cardiogenic shock? What's going to be different about that patient's hemodynamic profile? Well, duh, we already know that their cardiac output and index is going to be low. That's pretty much the problem in most of our shock states, is their output is not effective. It's not adequate for the patient. But why is that in cardiogenic shock? It's because the pump is broken. The left heart isn't able to push the blood out effectively. So where does the blood back up? Yep, it's going to back up in the pulmonary vasculature and then on the right side of the heart. That's why you see JVD on these patients, because it's backing up. So where are we going to see high pressures? Yeah, on the right side of the heart. So in the pulmonary artery, we're going to see high pressures. The CVP is going to be high because we've got a traffic jam, because the left ventricle is essentially, you know, when the highway is under construction and it goes down to one lane and not very much can get through, that's what's happening on the left side of the heart, right? So you're going to see inadequate cardiac output and index and really high pressures on the right side of the heart. Let's do one more. I'll make it quick because I'm about out of time on the TikTok time limit. Let's look at septic shock, right? Are we going to have adequate cardiac output and index? No, we already established that's pretty much the problem in all of our shock states. But is the pump working effectively? Mostly, but sometimes in septic shock, those cytokines can affect your anatropy and drop it just a little bit. But we also know that we're going to have low pressures on the right side of the heart. So your pulmonary artery pressure, your CVP are going to be low in your septic shock patients because we don't have preload, right? We've lost our vascular tone. We've lost some of our volume due to third spacing, because remember, we get that increased capillary permeability and plasma seeps out of the vasculature. So we're missing volume and we're missing vascular tone. So your CVP is going to be low on those patients. So guys, thanks for hanging with me. I know that was a really fast lesson, just looking at the very top view of the basics of the pulmonary artery catheter and invasive hemodynamics. I hope that helps you guys. I'll see you in the next video. Good luck if you're on duty.